to explain this, one has to start by thinking about methionine. This is an essential amino acid that we get in our food and that we need to use for protein synthesis. Any that is not used for protein synthesis is normally broken down via homocysteine, and in classical homocystinuria, the problem breaking it down means that homocysteine accumulates. So for dietary treatment, we restrict the amount of methionine in the diet so that we give just enough for protein synthesis, but not much more, so that not much needs to be broken down and less homocysteine is made. Now, if we have just a low protein diet, we can't restrict the methionine sufficiently without causing protein malnutrition. And so therefore, we have to approach this by giving a diet that is extremely low in natural protein with supplements of all the amino acids apart from methionine. So for babies, we give a combination of 2 infant formulas or milks. We give a special formula that contains all of the normal things in baby milk apart from protein. And then in addition, this special formula contains all of the amino acids except methionine. And then, as well as that special formula, we have to give some normal breast milk or some normal infant formula, which will then supply the methionine that is essential for protein synthesis and for the baby's growth. We then adjust the amount of the 2 formulas, or the 2 milks, to get the methionine and homocysteine concentrations in the target range. So that's how we do it for babies. When patients get older, we want them to take most of their food as solids and not to fill them up with these large volumes of milk. And so we need to then give small measured amounts of foods that contain protein along with the amino acid mixture in a more concentrated form than is found in the special infant formula. As well as this, we need to give low protein foods that will supply the energy for growth, and these may come in fruit and vegetables, most of which are very low in protein, or in synthetic artificial low protein foods. And so one can get low protein bread or low protein biscuits or low protein pasta available certainly in the UK on prescription. And then finally, one needs to give vitamins and minerals because most of the vitamins and minerals that we normally get come in our high protein foods. And so without supplements of those, one would develop vitamin or mineral malnutrition. And these vitamins and minerals are added already to most of the commercially available amino acid mixtures. One then does the fine-tuning of the diet according to the plasma homocysteine and methionine levels, just as you would in babies. There are a number of challenges. The first of these applies less to the UK than to certain other countries where the distances to specialist metabolic centres may be very large. And so for patients, particularly in other countries, sheer travel may be a big problem for the patients. One can, to some extent, overcome this by giving telephone advice, and also either by getting the blood samples taken locally, or some labs can actually measure the homocysteine in blood spots And so that can also minimize the number of visits. Some visits are essential for nutritional monitoring and things like that, but a lot of the visits can be minimized by the means we've just mentioned. A second problem that is seen in some families is needle phobia because of the frequent blood sampling. Parents do very well often in managing to minimize the impact of the blood tests on their patients, but still some patients do develop needle phobia, and then advice from play specialists can help to overcome this. A third problem is the expense and relative unpalatability of the amino acid mixtures and the low protein foods. In the UK, we are fortunate that these are actually covered by the NHS, but I'm aware that in other countries sometimes low protein foods are not covered, and sometimes health insurers can be quite difficult about reimbursing the costs for the amino acid mixtures. Clearly, these are issues that need to be taken up with the healthcare providers and also with the special medical food companies, and particularly for them, one needs to look at trying to persuade them to do more work on producing more palatable amino acid mixtures. The problem, of course, is that the number of patients with homocystinuria on dietary treatment is relatively small, and so much less work goes on in developing amino acid mixtures for these patients than for patients with PKU, which is considerably common. So I think that I would think of four main factors contributing to poor compliance. First, patients who are diagnosed after infancy find introducing the diet much more difficult. And this is obviously because they have already started having high protein foods and have got to like them. And then saying that they can't have any of these is very unpopular. And so that, I think, is a major problem. A second problem, of course, is adolescence, because as children get older and become adolescents or young adults, they want to be more like their peers. They rebel against the restrictions that their family and their physicians are imposing, so they often don't comply so well with their diet. So these are two of the big things. Other things, of course, are the attitude of their family and their friends. So if the father says, "My, this food is disgusting," it's not going to help with dietary compliance, is it? Finally, the child's personality will have an effect, and so some children are more amenable to diets than others. Sadly, late diagnosed patients, as part of the condition, often do have some behavior problems, and so this can exacerbate the problems with dietary compliance. But what can we do about the first two issues that I mentioned? Well, obviously, if one can diagnose patients by newborn screening, then that means that it's going to be easier to introduce the diet. And so I feel that newborn screening is something extremely positive in this condition. Unfortunately, it doesn't pick up all patients, but it does pick up most of the patients who don't respond to pyridoxine, and so it can be very, very helpful. And then, secondly, with regard to managing the deterioration in compliance that may happen at adolescence, the introduction of betaine can be very useful here in helping to lower the homocysteine levels if they drift up at this age. Sadly, betaine seldom is adequate to control the homocysteine levels in patients on a normal diet. It doesn't seem to be working adequately in isolation, but it can be very helpful combined with the diet. betaine has few side effects. It has a taste that not everybody likes, and at high doses it can cause a fishy smell. The main concern that people have is about the rise in methionine levels. And certainly there have been reports of brain swelling, of cerebral edema, in a few patients who have had methionine levels above 1,000 micromoles per litre. But again, if you are combining the treatment with betaine with a low methionine diet, then it is unlikely that levels will reach that stage, and betaine does seem to be very safe under other circumstances.